And then we're getting into some, so those are areas I think I do fairly well. There are areas like this, the next three that I think I have a lot to learn. So as I said, there are no experts in this area, just a lot of students. So bone health, nutritional review, and I'm going to really rely heavily on public health for this. So Ottawa Public Health has really done a great job in reviewing the literature, and what they recommend is for adults over 51 years old. Well, I'm going to be there in a couple of years. Wow. I'm going to have to start taking my vitamin D. So 3 or more servings of milk or alternatives, adequate calcium and vitamin D rich foods, and a vitamin D supplement of 400 units per day. So you'll see different guidelines, and I have some guidelines with me that kind of disagree with this. This is the best synthesis from a local perspective. A lot of people wonder, how can vitamin D prevent falls? Is it just preventing fractures? And there are RCTs and meta-analysis that indicate that there are positive effects of vitamin D that go beyond just bone strength. So we want to prevent falls. When people fall, we want to prevent fractures. But vitamin D apparently prevents the falls itself, not just the fractures. It improves muscle strength, and it may be involved in neuromuscular conduction. So it's doing some other things that we don't really expect. Most of us focus more on the bone health itself. So I'm sorry, the left column here should be calcium, and the right column should be vitamin D. So the recommendations from food and or supplement are women should be getting 1,200 milligrams of calcium, and men should be getting about 1,000 to 1,200 milligrams of calcium. So you'll have to look up websites to see, looking at the dietary review, are they getting enough? I can't pretend that I'm great at doing a dietary review, and that may be one of the bits of feedback that we need from you. Is this something you can do, you just do naturally already, or is this an area that you also struggle with, calculating how much calcium and vitamin D people are getting? So that might be an outcome of the pilot. And then on the right side, the vitamin D. So people 51 to 70 years old, women and men, should be getting 600 units, 71 plus 800 units. And as I said, people over 50 years should be getting a supplement of 400 units. So those are the recommendations to date, and we'll certainly welcome your input on how well you can operationalize that. Feet and footwear. Also something we all have to learn about, and I had a lot of help learning about this from the outreach team and from the RGP team. So don't forget, some of us doctors don't like to take off socks and shoes because they're kind of smelly, and we didn't get down to that part of the exam. But it's really, in someone who's falling, it's really important to take off the shoes and socks. And you'll learn a lot you didn't expect about the patient when you do that. You'll see signs of neglect. That may reflect neglect by a caregiver, may reflect depression, may reflect dementia, cognitive impairment. So when you look at the feet can tell you a lot. More specifically, what do you want to look at or look for? Moderate and severe bunions that are really having a lot of friction, causing a lot of pain, significant toe and nail deformities, overriding toes, ulcers. So there may be a room for chiropody here, and that's one of the consults that the algorithm recommends. It's an area of falls that I don't think has enough attention and where we can do a lot for people. Loss of position sense or proprioception, so can they sense if the toe is being moved up and down? And the best way to assess for that is really to spread the toe, have them close their eyes, spread the small toes aside, clamp on the sides of the big toe, and ask them if you're moving up or down. And they should be able to detect about 50% of that. That's really a gross test. The monofilament test that you use for diabetics and the vibration sense with the tuning fork are more sensitive tests. They're going to pick up peripheral neuropathies much more readily, the milder forms. But they may not be as specific. You might be picking up something that's not relevant to falls. So once again, I'm going to defer to your experience as you go through this regarding what you find is most useful. I have my own opinions, but I'm going to try not to bias your opinions too much. Don't forget to not think just about the feet and footwear. The AGS, American Geriatric Society, British Geriatric Society, looked at feet and footwear, but look at the whole lower body. So you're looking for pain in the muscles, atrophy of the muscles. Look not just at the feet, but at the ankle, knee, and hip. So you may have quite severe deformities, Charcot feet from loss of sensation, so very deformed feet. Look at pain control, as I mentioned before. I can't tell you how many people The outreach assessors can now tell me exactly what I'm going to say when they present a case. You know, please put this person on Tylenol arthritis, 1 tablet 650 milligrams TID straight, or 2 tablets 1300 milligrams TID straight, and then we'll assess mobility. So get the pain out of the way so we can assess the rest of the contributors to mobility. If that doesn't work, and if they don't have heart failure, renal dysfunction, or hypertension, consider an NSAID, and if necessary, narcotics. You're going to go up the WHO pain control ladder. Don't forget that heart failure can cause changes in the feet. So big, puffy, edematous feet can cause falls. People lose their proprioception. Plus they have these big, heavy feet to lift up. So that can alter the biomechanics and the sensation. The footwear. Many of us, most of us, don't do that very well. If at all possible, and I realize this is logistically difficult, ask them to bring in the shoes they were wearing when they fell. Or ask a loved one to describe the shoes as honestly as they possibly can without causing a fight. Because sometimes the loved ones are fighting with the person you're caring for about the shoes they wear. So you're looking for a shoe that doesn't fit well, where there's movement within the shoe as they're walking. Lack of support, so not laced or buckled or providing some ankle support. High heels are tricky. Some women have been using high heels extensively for years, and they develop shortening in the Achilles tendon. So you really have trouble getting them into low flat shoes. You can try to slowly go down on those heels, but that's a real challenge, and you might need to get a footwear specialist, a chiropodist, someone involved in that type of a situation. Small surface area. So the high-heeled shoes have a very small surface area relevant to flat shoes. So you're going to look at the shoe, you're going to say, is this touching the floor? First of all, is there enough surface area to prevent a slip and a slide and a fall? And then number two, is this a slippery sole? So the shoes I'm wearing right now are very slippery. They're very old, and all the tread's worn out. So that's bad. Or they might be designed that way. It might be a nice patent leather sole that has no gripping features. So if you can, look at the shoe or have them bring it in next time. It sounds small, but if this small thing can make a difference and can prevent a hip fracture or subdural, it becomes a big deal. So the small things make a big difference. Environmental hazards. We're also going to appreciate your input into this. How much can you gauge from the office setting without having someone go into the house? So we do have the benefit of the geriatric outreach team, and they provided a lot of this for me, but I don't see people at home. So relying on reports is very, very challenging. What we should be looking for are some hazards in the home. So poorly lit stairs, especially if people already have vision problems, or ramps, doorways. Stairs that are irregular, that have been adjusted, that are very old, that are not up to code. Stairs without railings. Stairs without marked edges. Slippery floors, throw rugs, loose carpets. Sills on doors that are raised too much and people are tripping over it. Clutter. Low toilet seats. So some people have weak quads, have a lot of difficulty getting off low toilet seats. They actually may need to get a different toilet, one of the larger, higher ones. Lack of grab bars in the bathroom, and then poorly maintained mobility aids. So look at their walker and look at whether it's falling apart. Look at whether the brakes actually work. Look at whether it can be locked in place. Look at whether it's stable, and look at the height. So the height of a cane or walker should be roughly, when they're standing, should be roughly at the crease in the wrist or at the greater trochanter. So what you want, greater trochanter in the hip. So what you want is when they're standing, you want a little bit of bend. You don't want their hands to be fully extended, because then if they put the cane or walker down off a curb, they're going to be leaning over it and they're going to fall. You also don't want a woman to have her husband's old cane or walker that's super high, so her hand's way up here, because the torque forces are enormous. So you want a little bit of bend, about 10 to 15 degrees there, so there's some play they can go down a curb, but not huge torque forces. So is it well maintained? Do the brakes work? Is it the right size? And certainly refer on to somebody who knows more about canes and walkers to see if they have the right one. Outdoor hazards, and winter's coming, these are just going to escalate. So sidewalks, cracks in sidewalks, at least you can find out about their house. You know, their walkway, their steps going in and out of the house, whether they're maintained, whether there's good lighting, whether there's snow or ice on the walkways, whether they're salting the driveways. Another mea culpa, I remember one winter I fell twice. Why? Not because I had balance problems. So I always listen to the story of the fall. Because I had poor judgment or I was lazy, I didn't salt the driveway. So both times I was carrying the garbage can out on an icy driveway. So listen to the mechanism of the fall and ask, is this a balance problem or is this a judgment problem? It's a judgment problem, but I'm trainable, so that's gone away. It's been cured. And then, you know, long crosswalks in the neighborhood, inability to cross the road. So different ways to approach this. Ask the patient and family about difficulty getting out of bed, getting off low chairs, getting off the toilet, tripping over rugs, thresholds, lighting, and stairs. So these are shorter, faster ways to approach this, and we'll give you a sense of risk reduction strategies. Sometimes a story will at least tell you, I need to send someone into the home. There's something going on here, and I can't fix this from an office. And this is another list that you can look at. This is just a reiteration of what I've been talking about, a different way of framing some of the questions. So I won't go into this because you can read this. It's in the handout and it's going to be on the website. And then finally, depression. I'm not going to go into depression in great detail. Anxiety, panic disorders can cause falls. So always think about depression, especially if the person's falling. Depression may cause the falls, may contribute, but it also may be the result. They're falling, so they're starting to restrict their activities, not going out of the house, and becoming socially withdrawn. So it's hard to tell if it's caused. Well, the goals of treatment, why are we doing all of this? And sometimes I have to remind myself, prevent falls as much as you can. Preventing all falls is often unachievable. Everybody falls sometimes. Sometimes the environmental stressor is just too much. It was an ice storm, I had to go out, had to let the cat out, and I fell down. Since we can't prevent all falls, we also want to prevent fractures. So if someone is having near falls or falls, if they're at fall risk, do think about a bone mineral density and do think about treating osteoporosis and osteopenia. If they just have osteopenia, calcium, vitamin D. If it's osteoporosis, calcium, vitamin D, bisphosphonate, if they can tolerate it, or some of the other drugs. If they've already had one fragility fracture, which very simply means a fracture that you or I would not have with a minor fall, then you have to think about osteoporosis and treatment. So how do we treat falls? How can we manage this? Is this a one-person show? Absolutely not. You already have a sense of the extreme depth you have to go through. If you know the patient, you can, however, fly through a lot of this stuff. You can say, a lot of this stuff is not pertinent to this person. I know they don't have aortic stenosis. I know they don't have arrhythmias. I can skip over some of that stuff. So what does the team generally do? The physician, the nurse, and possibly the pharmacist are adjusting medications, stopping them for the most part. The two classes of medications we might be starting are medications for pain or medications for Parkinson's. Or if people have orthostatic hypotension, midodrine, some of the other amantine, so drugs that can increase blood pressure. So those are the rare drugs you would start, but usually it's decreasing or stopping the drugs, optimizing control of their other problems like their diabetes, their CHF, and considering a bone density. Occupational therapists, looking at compensatory strategies, planning around the deficits, education, assistive devices to deal with some of the deficits, physiotherapy, balance and strength training, and ambulation aids. I'm not capturing all of what everyone does, just kind of the highlights. Social work is the person living in a house that they can possibly safely negotiate, and maybe they're not. And looking at some support services and maybe some programs that people can go to. Nutrition, as I described with the person with dementia, people are put on cholinesterase inhibitors, they lose 30 pounds, they start to fall. If people have lost a significant amount of weight, a lot of that is muscle. They may also have postural hypotension. So nutrition can sometimes, if there's progressive weight loss, that can become your number one issue. If you cannot turn around the progressive weight loss and get weight back on somewhere close to their normal baseline, you may not be able to get anywhere. That can become number one. So that's generally what all of us do. I'm missing stuff the MDs do and the OTs do and physio, the other team members do. But this gives you a general sense of how people compensate each other's professional skills. So, I'm just going to show you one thing on our website. As I said, we're going to try to download or upload as much of this as we can, as many resources as we can, so that if you want to look at the algorithm, if you want some resources, how do I deal with postural hypotension, it's going to be loaded on this. So go to rgpeo.com, so rgpeo.com, look at the Home tab. Under this, look under where the red arrow is, the fall prevention. That will bring you to this page. And here you're going to have fall risk assessment and intervention resources, community resources, and other resources. So throughout this trial, we're going to keep populating this as much as we possibly can. And then this this is what I've been talking about. If you really want to get into one of these, we're going to have not only the slides, but we're going to try to link in articles that may be of help if you want to dig a bit deeper in some of the topics. And this will be on the Champlain Health Line, so our main website of resources. So we're going to be building things in, so it'll be iterative. You can go to Champlain Health Line, get to the Regional Geriatric Program website, and vice versa. So you'll be able to go back and forth. So we're going to keep building resources for you, and certainly if you have things that you think are relevant, you should let us know.